So thank you everyone for joining us. We're lucky to have Dr. Bernstein with us for the first session, one of the endocrinology attendings here to talk about thyroid diseases. Whenever you want to get started, Dr. Bernstein.
Hi, thank you. It's a pleasure to be here. I actually started out my career in endocrinology in the thyroid lab at the NIH, so it's been a long time. I might refer back to it at some point. These are the things that I'm going to present in detail. Some of these things I added in, like amiodarone has become such an important topic to endocrinology and cardiology, and so the interaction is very important. What you will notice on here is that I did not mention hypothyroidism or hyperthyroidism. And that doesn't mean I'm going to ignore them. I mean, there are basically two medications to treat hyperthyroidism and one to treat hypothyroidism. And you're probably all familiar with it, but there are a lot of things that I notice as I meet with people that are somewhat misunderstood. And so these are some of the things that I'm going to talk about here. First of all, the symptoms ascribed to thyroid disease were derived back when we couldn't really diagnose hypothyroidism. Hypothyroidism, the TSH didn't exist back in the 1960s, and the thyroxine wasn't even directly measured. And people didn't get diagnosed until they were far advanced. So now most of the people we see don't have any symptoms related to their hypothyroidism. The patients may come in with symptoms. They can tell you that they have fatigue and weight gain and constipation and they're cold and they're losing hair. Those are unfortunately very common in people without thyroid disease. And most of the time when you treat them, you can get this response of, oh, nothing happened, so the treatment isn't working, which is incorrect, or that I felt better the first day after I took it, which is incorrect because it takes a long time for the levothyroxine levels to build up in the body. So there's a lot of placebo effect there. Similarly, in hyperthyroidism, people tell me, oh, the TSH is suppressed, it's very severe hyperthyroidism. The TSH is suppressed in very mild hyperthyroidism, even in subclinical hyperthyroidism in many cases. And so you really need the thyroid hormones themselves to gauge the severity of the hyperthyroidism and the efficacy of treatment. And the TSH alone isn't sufficient. Similarly, people show up in my office all the time. Oh, they've got an abnormal thyroid test. They have an abnormal anti-TPO. The thyroid peroxidase antibody is a marker of autoimmune thyroid disease, but it doesn't cause it. T cells cause it. And the levels are not proportional to anything that's going on. So once you know that it is autoimmune thyroid disease, you don't have to do anything. Most spontaneous hypothyroidism is autoimmune. Otherwise, it's hypothyroidism that we produced with surgery or similar things, or rarely congenital hypothyroidism, but most of it is autoimmune. Now, in contrast, in Graves' disease, the TSH receptor antibody is what causes the thyroid disease. It binds to the TSH receptor and it stimulates. And so those antibodies, the TSH receptor antibody or the TBII or God, I lost the name, but the various things that are the Graves' disease related antibodies are important, and they can tell whether the underlying disease is going away or not, because the anti-thyroid agents don't treat the underlying disease. And the final thing is, and I alluded to this, that the thyroid hormones are bound to TBG. Most of the thyroid hormone in the blood is bound. The free hormone changes very slowly, and the turnover time of thyroxine is 8 to 10 days half-life. So everything happens very slowly. Similarly, the anti-thyroid agents may block production of thyroid hormone, but there's preformed thyroid hormone that still can be released. So nothing happens immediately. Now, this first case is somebody who, I look at her as manna from heaven, because it was right after I agreed to do with this that she showed up in clinic. She shows a lot of the things that I wanted to talk about. So she came into the hospital about 2 months before I saw her, and she was in congestive heart failure, rapid atrial fibrillation, an ejection fraction of 15%, clearly they wanted to find out whether she was hyperthyroid, and the TSH was normal, and so they didn't pay attention to the other two things which were there. And then to make things more interesting, as is appropriate, she was treated with amiodarone, which has many effects on the thyroid. But the reason she came to clinic was an incidental thyroid nodule that was seen on a CT scan. And that also was an interesting thyroid nodule. So I could really talk about her for 2 hours. When we saw her, her reverse T3 was a little bit elevated. It was 26.2. So the diagnosis was what's called the euthyroid 6 syndrome. That's why the T3 was low, and the reverse T3 is a little more complex by the time you see her 2 months later. This is something that we see a lot in the hospital, so it's going to be one of the things I'm going to talk about. Now, I want to go into thyroid physiology because it actually is interesting and important in your understanding. So at the top of the screen is the formula for thyroxine. And what you look at on the left is what's called the outer ring, on the right, or the 5' ring on the right is the inner ring. And the inner ring is an iodinated tyrosine, and the outer ring is connected by an ether bond. In order for thyroid hormones to have biological activity, you have to have the 2 iodines on the inner ring. And that's because of stereochemistry, and I don't think we have to get into that. So T3 has one of the iodines missing on the outer ring, and reverse T3, which is inactive, has an iodine missing on the inner ring. So this is a very complex slide of the thyroid hormone biosynthesis, but the steps are important. So on the far right side is the sodium iodide symporter, which we used to call the iodine trap. And this is what it takes iodine from the plasma and sends it into the thyroid. It's stimulated by TSH. It can be blocked by perchlorate. It can be blocked by lithium partially, and it can be blocked by excess iodine, and that's called the Wolff-Chaikoff effect. And the reason I'll mention the Wolff-Chaikoff effect is that one of the first people I worked with in thyroid physiology was Jan Wolff, who it was named after. But be that as it may, the iodine then gets transported into the thyroglobulin and oxidized to a free radical, where it can then if you go down on the slide on the left side, it's bound to tyrosine molecules that are part of the nascent thyroglobulin. And then there's this conjugation step, and I don't know exactly how that is done. And then in signal from TSH or TSH receptor antibody, it's brought into the cell by endocytosis, it's hydrolyzed, the thyroid hormones are released, and all the other amino acids are released and not relevant. So you wind up secreting T4 and T3. And then the second important thing is that most of the T3 is actually made in the liver from T4. And this is by deiodination, and I'll get into that. The liver is also the place where thyroid hormones are excreted into the gut, and they can then be brought back into the circulation, and so that there's an enterohepatic circulation of the thyroid hormones. And then obviously they go to the various cells where they are active. The only one of them that is actually directly active is T3. T4 needs to be deiodinated to T3 in order to be active. Most cells have a deiodinase which can do that, and we'll get into the deiodinases right now. So, because they're very important in a lot of these syndromes. So the type 1 deiodinase is the one that I mentioned that's active in the liver and converts T4 to T3. And the important thing about that is that there are a lot of things which inhibit that deiodinase. So malnutrition, sepsis, various other types of illness, some medications can inhibit that deiodinase. And if that's happening, then the T3 levels go down. So this is where the findings in the sick thyroid syndrome are developed. Now, the type 2 deiodinase is present in the other cells, and they do an intracellular conversion of T4 to T3. The T3 is bound to nuclear receptors, and it's active that way. And all over the rest of the body, including the liver, there is the type 3 deiodinase, which deionates the inner ring and converts T4 to reverse T3. It converts T3 to another inactive form, and those are excreted. Now, in the euthyroid sick syndrome, I don't like to call it a syndrome because it's mostly a lab abnormality. And when we started measuring these things, we found people with low T3, and we didn't know what was going on, and they didn't seem like they had thyroid disease. And the question was whether we would treat them. So as it turns out, sick euthyroid syndrome is the result of the inhibition of the type 1 deiodinase. Then the rest of it is converted to reverse T3. Now, why would teleologically, why would you have this? And it turns out that if you semi-starve a person and the T3 goes down, when you're trying to do this for weight loss, you would like to increase the metabolic rate. So people try to replace the T3. And what turned out is that they were losing a lot of lean body mass and a lot of protein with that. So that this effect is mainly to reduce the catabolic effect of T3. Whether one has to ever treat the euthyroid sick syndrome is unclear, and nobody's ever going to be able to really do a good study to find out. And there is some thought that a low dose of levothyroxine, particularly in people who are obturated, may be helpful. And we've actually seen this in some of the people here. Now, the second thing, this patient was treated with amiodarone. So amiodarone is a very useful drug. It's loaded with iodine. The 200 milligram amiodarone tablet releases about 3 milligrams of iodine a day. The thyroid needs about 100 micrograms of iodine, and the rest of it is going to go into the circulation. And also amiodarone is lipophilic, so it has a very long half-life. And I get the question all the time, should I stop the amiodarone? And the answer is no, it's not going to make any difference. It's there. It's the gift that still keeps giving. And we just have to treat the amiodarone effects. So what does the amiodarone, pardon me, what does it do? There's a direct effect which I alluded to, which is that it blocks both deiodinase 1 and deiodinase 2. So therefore, there's a higher T4 and a lower T3 and an increased reverse T3 in the blood. But the more important effect of amiodarone is the thyroiditis that it can cause. That's a direct effect, and it's called type 2 hyperthyroidism. And it can cause very severe illness and very difficult to treat, as we'll discuss. Now, the iodine itself can exacerbate the hypothyroidism. This, I mentioned the Wolff-Chaikoff effect. Normally, when iodine blocks uptake into the thyroid, there's an escape from it. But in people with autoimmune thyroid disease, that escape isn't always present. And so if you give amiodarone to a person with hypothyroidism or Hashimoto's disease, they can get an exacerbation of the hypothyroidism. And the other thing is that can happen from this iodine is the opposite. That if you take in a lot of that iodine, and particularly if the thyroid has been iodine deficient and there's underlying hyperthyroidism, you can get a more severe hyperthyroidism. That's called type 1 hyperthyroidism. And it's important, if possible, to differentiate between type 1 and type 2. But you can't do a radioactive iodine uptake because radioactive iodine uptake is suppressed by the large amounts of iodine. So we look at blood flow, or the radiologists look at blood flow if they're good, and that can be done with a color Doppler or a sestamibi scan, and there's increased blood flow in type 1 and decreased in type 2. And the reason that this is important is that the type 2 hyperthyroidism does not respond to anti-thyroid agents because the thyroid's already damaged and the TSH is already suppressed. So type 1 can be treated with high doses of methimazole, but do have increased risk of agranulocytosis. Fortunately, it's quite rare, but it can be there. But you need high doses of methimazole for that. Type 2 can be treated only with steroids, and if the steroids are ineffective, surgery is the only other option. I get the question a lot on rounds, well, with a patient who's hypothyroid from amiodarone, should this patient be put on steroids? And the answer is no. The treatment of hypothyroidism from amiodarone is very simple. You give thyroid hormone. So now the third thing that this patient showed up with was a thyroid nodule. And you people probably run into thyroid nodules very frequently in the clinic and in the wards. Thyroid nodules, microscopic thyroid nodules, are very common. They increase with age. They're more common in women. Over 80% of women over 60 have at least one thyroid nodule. And furthermore, thyroid carcinomas are present. Back in the 1950s, they did autopsy studies at the Mayo Clinic, and that have been repeated in a lot of places. And 4 to 8% of people who had no known thyroid disease had thyroid carcinoma. And then it turns out that it's partly ethnically based, so that people with Finnish or Japanese backgrounds, even those who are living in the United States and not exposed to any of the environment there, have over 20% incidence of carcinomas on autopsy studies. So the carcinomas aren't really that much of a concern. We follow papillary thyroid carcinomas that are less than a centimeter that are known. There have been studies done in Japan, and another one is being done at Sloan Kettering. And over a follow-up of 20 or more years, 80 to 90% of the people have no enlargement of those small carcinomas, and there's no reason to do anything. And if they do enlarge, the cure by surgery is 100%. So, we do the studies of thyroid nodules to look for carcinomas, because not all carcinomas are this benign, but most of them we don't have to worry about. And the evidence of this is that the death rate has not increased since the 1960s, when we didn't have ultrasounds and all that we had was what we could feel. So I must point out that the one thing that we could do to prevent overdiagnosis is to not do inappropriate ultrasounds. So screening ultrasounds aren't useful because they don't change the prognosis. Ultrasound tells you nothing in evaluation of people with elevated TSH. The nodules don't cause hypothyroidism, and people with hypothyroidism or Hashimoto's disease don't have an increased incidence of nodules. So there's no reason to screen hypothyroid patients with ultrasounds. Hyperthyroid patients may have functioning nodules, but those can be detected much more easily and much more appropriately with nuclear scans, which can distinguish between a functioning and a non-functioning nodule. And most importantly, at least with the referrals we get here, when I ask the patient, why did they do your ultrasound? They say, oh, well, I came in and I was having trouble swallowing, or I was having pain in my neck. Usually the pain that the area they point to isn't even over the thyroid. So they did the ultrasound. Now, it's very rare for thyroid nodules to cause neck pain or dysphagia unless they're huge or tender. So if you're going to evaluate dysphagia, they need an ENT evaluation, not a thyroid ultrasound. So having said that, there are times when we are concerned. Nodules that appear in childhood are more commonly malignant and can be aggressive malignancies. So that's one thing. Exposure to environmental ionizing radiation has been shown in places such as the Marshall Islands after the H-bomb tests in the 1960s, 1950s, and after the Chernobyl accident, and I'm sure it's going to be shown after the one in Japan. The ionizing radiation can cause thyroid carcinoma in children under 5 at the time of the radiation. And the reason that the age is important is that the radioactive iodine is delivered in milk, and by giving Lugol solution or SSKI and blocking uptake into the thyroid, you can prevent this. And after Chernobyl, they did that in Poland, and they didn't have an increase of thyroid nodules or thyroid cancer, as opposed to Belarus and to some of the Scandinavian countries where they didn't give the iodine prophylaxis. Then there are some strange things, like there in coal mining regions in many parts of the world, there are environmental goitrogens which cause nodules and cause thyroid carcinoma. And there have been epidemiologic studies of this. And people with MEN2 syndrome have familial medullary thyroid carcinoma, but there are also familial papillary carcinoma. So those are things where we do look carefully for cancer. Now this patient, oh, pardon me, this is the TIRADS classification that the American College of Radiology has done, and it's actually very good. So on the top, there are the 5 squares, and there are features of these nodules which are of higher risk. So solid nodules are of higher risk than cystic ones or spongiform ones. If the nodule is very hypoechoic, meaning on the ultrasound that there's less echo than in the strap muscles, that's a high risk. Most thyroid nodules are wider than tall because that's the plane of the thyroid tissue. If they're taller than wide, that's an indication of potential risk. If it has a very irregular lobulated nodule, or if it's exophytic, that is an indication of possible risk. And then the other thing which is important are the punctate echogenic foci, which were originally called Samoma bodies, but nobody remembers that name. And so putting all these things together, when you see the radiology report, it gives the thyroid classification, which is at the bottom. And as you'll see on those thyroid classifications, the size of the nodule is also important. And the larger it is, the more there's reason to do an FNA. So now this patient, and I don't think the picture is very good, but this is the nodule that this patient had. This is the skin. This is strap muscle, and the nodule is irregular. It's taller than wide. It's got microcalcifications in it. It's exophytic right here. So this, when I saw this and when Dr. Taya saw this, we got very concerned. Fortunately for this patient, it was benign. Dr. Taya, for those of you who don't know, is our endocrine surgeon who comes here, and she's wonderful. And I depend on her a lot. So when they do the fine needle aspiration, there's an evaluation. This is the Bethesda system. And Bethesda 2 is a benign nodule. 5 and 6 are ones that you are going to want to do surgery on regardless. 3 and 4 are intermediate. So the AUS is atypia of unknown significance. FLUS is follicular lesion of unknown significance. And then the other 2 are follicular neoplasm and suspected follicular neoplasm. Those 2, when they do the fine needle aspiration, they also send tissue to the company that does it, that does the evaluation, and they, if it's in those 2 categories, they do a test of the DNA, and you can grade the risk from the 3% that's there with a benign lesion up to 70, 80, 90%. And so that's how we make decisions about which ones we're worried about and which ones require surgery. Okay, so we'll get to questions at the end of the time, but I'll bring in another case. In this case, which is fictitious, this is a 28-year-old woman who had a normal pregnancy, came in for a postnatal visit in month 3, reported anxiety, mood swings, palpitations, Now, unfortunately, any of you who've been a parent know that newborn parenthood has these same symptoms. But in this case, the patient has hyperthyroidism, and you can see this on the suppressed TSH and the elevated free T4 and free T3. But the SED rate is elevated, the TSH receptor and TSI are not elevated. So this is not Graves' disease, this is a thyroiditis, and that's indicated by the anti-TPO. The thyroid is enlarged, there's a heterogeneous echo texture, and this is a fictitious case of postpartum thyroiditis. And so it follows a course with initial hyperthyroidism in most cases, followed by hypothyroidism, which can be transient or permanent. And it's believed to be the escape from the immunosuppression that occurs during pregnancy, so that patients who have underlying autoimmune disease get an exacerbation after delivery. And this is what causes the postpartum thyroiditis. Now, the thyroiditis is again, it's a lumped together form of diagnosis. There are a lot of different forms, and they have some shared characteristics. There's inflammation, of course, that's how it's named thyroiditis. The ultrasound will show a heterogeneous echo texture. There may be pain and tenderness, and it sometimes can be severe. It may start out hyperthyroid from damage to the follicles. If this happens, then it goes through a period of hypothyroidism because even when the follicles heal, the TSH lags behind, so they have no stimulation of the now healed follicles. And then it can go on to hypothyroidism. The radioactive iodine uptake is low in the hyperthyroid phase and the hypothyroid phase. So that's one of the things. The SED rate is elevated, and if you catch it at that time, you can make a diagnosis very quickly. Now, so the most common type of thyroiditis is subacute thyroiditis. And this is a viral illness. We don't know specifically what virus is, except that since we're now in the year 2021, there has been subacute thyroiditis in patients with COVID. And one of our fellows did a survey of the people at Beth Israel and showed the pattern of subacute thyroiditis in many of these patients. So it starts out with a hyperthyroid phase and often with pain or tenderness. As I said, the SED rate is elevated. The thyroid antibodies in this case are normal. If left untreated, it resolves itself. It goes through a hypothyroid phase. It then goes back to normal, and it takes about 3 to 6 months to accomplish. It's usually closer to the 3. Usually the hyperthyroidism doesn't need to be treated. If it needs to be treated, you need to use beta blockers because it's not going to respond to antithyroid drugs. The hypothyroidism is, I've never seen it where it needs treatment unless it's prolonged. If the patient is having pain and tenderness, non-steroidals usually work, and rarely they need steroids. Painless thyroiditis and postpartum thyroiditis are essentially similar. They're both types of Hashimoto's disease with initial hyperthyroidism. Hashimoto's has a much slower course. When you see a patient with elevated TPO and maybe a TSH of 5, this is called subclinical hypothyroidism. And if you follow it, it's a median of 10 years before there's symptomatic hypothyroidism developing. And many of them don't ever develop symptomatic hypothyroidism. And there's no treatment that's going to change this. And the patients don't need treatment until it's clearly progressing. So they did a study in a health fair in Colorado in the 1980s. And they just, they gave everybody a questionnaire and they measured everybody's TSH. And there was no difference in symptoms between people with elevated TSH and normal TSH until the TSH was over 12. And so that's where this number 12 came from. That was an arbitrary number also. Now, other types of thyroiditis are less common. I've never seen a case of Rydell's thyroiditis. I saw one case of suppurative thyroiditis, and that's basically an abscess in the thyroid. But the drug-induced thyroiditis does exist. Amiodarone I've spoken about. The lithium and most of the other things listed here don't cause a hyperthyroid phase and are relatively uncommon. But now the checkpoint inhibitors have become a major cause of thyroid and other autoimmune disease. And so the first patient I saw who had been on Keytruda, I said, well, your stage 4 lung cancer has been cured, but you're hypothyroid and you're diabetic. And I make that trade-off anytime. But we do watch them very closely and see. Interestingly, the antibodies are not elevated in people with checkpoint inhibitor-induced autoimmune disease. Okay, now we're going to go on to a final fictitious case. This is a 62-year-old man who had Graves' disease, had been on methimazole, ran out of his medication a month before admission. He came in, he was agitated, disoriented, in rapid atrial fibrillation, febrile, in congestive failure, and pretty sick. His thyroid was soft and enlarged and had a positive Brulee, so this is what we see in Graves' disease, and he was hyperthyroid. Now, I also put in his glucose and calcium are elevated. The glucose is elevated in this syndrome because of the stress, and the calcium because of the dehydration that's frequently seen. So this is a classical presentation of thyroid storm. Now, despite what you would think, there's no difference in the thyroid hormone levels between people with thyroid storm and other people with symptomatic hyperthyroidism. In fact, the only difference when you go through and survey them is the central nervous system symptoms. Otherwise, the laboratory findings and many of the physical findings are similar. The underlying disease can be anything that causes hyperthyroidism, including Graves' disease, functioning nodules, and thyroiditis. And our friend amiodarone comes into that. That's how that develops. But there are precipitating factors, and so sepsis is a precipitating factor. Any kind of surgery is a precipitating factor, and we occasionally used to see people post-surgically who had thyroid storm who they didn't know were hyperthyroidism. The surgeons are now a little bit more careful about that. Cessation of antithyroid medication is a precipitating factor, and a sudden iodine load in people who are iodine deficient can be a precipitating factor. And the management is multifactorial, as we'll see. This is called the Birch-Bortovsky score. And every time that they present a patient, they tell me the Birch-Bortovsky score. I think it basically just gives grades to all of the things that you're going to find in thyroid storm. And I think it's useful for a research study where you have to have an objective way of distinguishing, but it's not very useful clinically. If a patient comes in and is really sick and they don't have a 45 on the Birch-Bortovsky score, you're still going to treat them aggressively. And and the treatment is going to be pretty much the same because the treatment is symptomatic as well as supportive. It's worthwhile knowing that it exists, but I don't have to know the number. So what do we do? Well, the supportive measures are extremely important. IV rehydration, keeping watch on congestive heart failure, obviously. Stress doses of hydrocortisone, treatment of the underlying diseases, treatment of diabetes if it develops. But the most important things are heart rate control and treatment of the hyperthyroidism. So when we use medication for heart rate control, the choice is usually propranolol. First of all, it blocks T4 to T3 deiodination. It can be given intravenously and monitored very closely for heart rate control. You need high doses of propranolol. Some people, if the patient has severe congestive heart failure, feel that metoprolol or carvedilol are preferable, and there's good reason for that. But most of the congestive heart failure is rate related, and rate control alone can treat the congestive heart failure, and this is why propranolol is still the drug of choice. Now, treatment of the thyroid is more difficult. As I pointed out, there's preformed thyroid hormone, and there's a slow turnover of levothyroxine. So getting the thyroid hormone levels down is difficult. You start out with antithyroid agents, and PTU is preferred unless there's a contraindication, because it inhibits conversion of T4 to T3. It again blocks that deiodinase 1. The dose is very high. Both these doses that I put up here are greater than the dose that is necessary to totally block thyroid hormone synthesis in normal thyroids. But there's an increased turnover of all medications. The second thing is to block hormone secretion. We give iodine either as Lugol solution or SSKI. But it's important to start the thionamide first and wait at least an hour so that you don't take in the iodine in the Lugol solution or the SSKI, and you don't get an exacerbation instead of a relief of the hyperthyroidism. Cholestyramine, I don't think many of you have used it for what it was originally for, which was to treat hypercholesterolemia, but it's an ion exchange resin and it binds thyroid hormones in the gut and isn't absorbed, so it helps the excretion of thyroid hormones. And those are basically the things we can do. Iopanoic acid was used to do oral cholecystograms. Since nobody does oral cholecystograms anymore, there isn't any iopanoic acid around. Plasmapheresis may be helpful. If none of these work, they need surgery, and in that case, you need really aggressive rate control and aggressive treatment with the Lugols or the SSKI, and it should be done within a week because you don't want to have escape from the block by the iodine. So that's a difficult thing, and there is still a high mortality in thyroid storm, and it's something that needs to be treated promptly and aggressively. So I think I've come to the end of this, and I'll take questions from anybody who has questions.
Thank you so much, Dr. Bernstein. If anyone has any questions, you can feel free to unmute yourselves now or post it in the chat as well.
Oh, come on. I wasn't that clear, and I don't think I totally bored you, so somebody has questions.
No, it was great.
Okay.
I have a question, actually. Hi, Dr. Bernstein. I'm Sophia. I'm one of the third years.
Yes, hi.
So going back to your initial remark about symptoms being very nonspecific and common, given that, just wondering, do you have any thoughts about reconsidering how we like a different approach to diagnosis, or maybe screening for thyroid abnormalities?
Well, we do screen for thyroid abnormalities. In most physical examinations, a TSH is done as part of the routine physical, and I think that that's important. And the reason that we screen for it is what I pointed out, which is that the hypothyroidism develops very slowly, and it's not symptomatic until the thyroid hormones, until the T3 level is low. And so we pick it up and we follow it. And if the patient is symptomatic, you know, I mean, these are common symptoms, but if you think the patient is symptomatic, there's no harm in treating with levothyroxine as long as you don't give excessive doses. And you can very safely give up to 75 micrograms because that's less than where the amount that's absorbed, which is about 50 micrograms, is less than the normal thyroid is secreting. So all you're doing is replacing some of your normal thyroid hormone with the exogenous hormone. And since they are absolutely identical, the synthetic levothyroxine and the levothyroxine that comes from your thyroid are absolutely identical. It's perfectly safe, and if it works, even if it's a placebo effect, that's okay too.
Thank you, Dr. Bernstein. And we also have two questions in the chat. So the first one from Fatma is, do we treat postpartum thyroiditis in the hyperthyroid stage, so PTU methimazole or just propranolol? And then the second question.
I'm sorry, what were we treating?
Postpartum thyroiditis.
Postpartum, okay, yeah.
Yeah.
Okay, yeah. So the answer is that the anti-thyroid agents don't work on thyroiditis. So you do rate control. Fortunately, it's a relatively transient disorder. And so usually you don't have to do much treatment. The second thing is that methimazole and PTU are both excreted in breast milk. So that's another reason that you're very careful about using those in the postpartum period.
Thank you. And then Lady had a question. If the patient is allergic to Synthroid, so a severe allergy with anaphylaxis, what are your other options?
Well, tell me how a person can be allergic to Synthroid with anaphylaxis like that. Or let's not say Synthroid, it's levothyroxine. Synthroid is an expensive brand of levothyroxine. But this is a natural hormone that's present in your body. You don't get anaphylactic reactions to it.
So
you may get anaphylactic reactions to other ingredients in the tablets. So the tablets, you can have dyes that you can get allergic reactions to, or other excipients. The 100 microgram Synthroid tablet has no dye in it. And so if necessary, you can do that. And also, I didn't mention that when you're treating with thyroxine, it's the cumulative amount you're giving. So you can treat with less than daily medication. In fact, you can treat a patient with weekly medication without having any adverse effects. And this is sometimes helpful in a non-compliant patient. If you can get somebody to come in and give it to them once a week, then they'll get their medication.
Thank you so much for that answer. So the reason why I asked is we have a patient at the clinic who came and was on Synthroid, and we wanted to restart it, but his patient just insisted that no, because he has a bad reaction, like allergic reaction, which includes shortness of breath and rashes, which sounds like anaphylaxis. So we have to consult some of our the endocrine specialists to ask, have they seen that before, and what are the other options that is available for this patient, because we are kind of not comfortable restarting the medication.
Yes, well, you know, there are also certain things. There's what's called a nocebo reaction, which is a placebo reaction that's an adverse reaction. And there is something, if you took logic courses in college, called a logical fallacy called post hoc ergo propter hoc, which means if it happened after this, it must be caused by that, which is obviously not necessarily the case. And we run into this all the time when people are talking about having medication reactions.
Okay, thank you.
We have a couple more questions in the chat, Dr. Bernstein, if it doesn't hold you up from making your ceremony. But Jonathan Jamito had a question. What is your opinion on TSH testing in patients admitted who are sick from a general non-thyroid illness?
Well, you mean when they're just doing it routinely on admission, checking the TSH?
Yeah, I guess on patients who are sick, maybe it's on the differential, but they're admitted with a non-thyroidal illness, checking TSH on the inpatient setting.
Well, I think that's fine. And if they're, but probably you should also check the thyroid hormones, unless you're just doing it as a routine screen. But if you think that there's a possibility of some abnormality, you should check the T4 and T3. However, if you're talking about sick euthyroid syndrome, it's worthwhile recognizing it, but it doesn't usually need to be treated.
Thank you. And we have one last question from Christina. Clinically, is it relevant to differentiate type 1 versus type 2 amiodarone-induced thyroiditis? Do you give both steroids and methimazole in these patients at the same time?
Yes, yes. In fact, that's often the case because, you know, the radiologic studies take time and you don't have time necessarily. And it's not easy to do them. So yes, you know, what I would do in that situation is to start on a high dose of methimazole and look and see whether there's any improvement, and probably do beta blockade also. And if nothing seems to be working, I would add in the steroids, knowing that I can always stop them. And we use steroids for all sorts of things, and you somehow feel free to use them without worrying about the adverse effects from the steroids, because the beneficial effects are greater than the adverse effects.
Thank you so much for that, Dr. Bernstein, and for your talk today. It was great.
Well, thank you very much. I enjoyed it.